Welcome to the Attention Deficit Disorder Expert Podcast Series by Attitude Magazine.
Hello, everyone, and we're glad you can attend Attitude's weekly ADHD Experts webinar. We hope that everyone is staying safe and staying well. Just some housekeeping before we get started. If you've listened to one of our webinars before, you know we offer attendees a certificate of attendance. When the webinar ends, a post-event survey will pop up. It will list 3 questions about the quality of the webinar, followed by 3 questions titled Required for Certificate. If you would like a certificate of attendance emailed to you, you should answer those 3 questions. If you don't want a certificate, then obviously don't bother answering them. Just wanted to point out the sponsor of today's webinar is Play Attention Virtual Summer Camp. For over 25 years, Play Attention has been helping children and adults thrive and succeed at school, home, and work. Their NASA-inspired technology and cognitive exercises improve executive function and self-regulation. Each program includes a lifetime membership and a personal executive function coach to customize your plan along the way. Call 800-788-6786 or go to www.playattention.com, or you can click on the hyperlink on your screen. Children and adult campers are welcome. Free consultation available. Attitude wants to thank our sponsors for supporting our webinars, but sponsorship has no influence on speaker selection or webinar content. Today's topic is key to all parents. The latest standards on how to evaluate, diagnose, and treat children with ADHD. You should know that the American Academy of Pediatrics revised its ADHD clinical guidelines last year to promote optimal care for children with the condition. Understanding these new standards of care will empower parents to work effectively with their pediatricians. Today, we will review the evidence that supports the AAP recommendations and clarify the role that the clinicians can play in diagnosing, treating, following up, monitoring, and if needed, referring children for additional services. Thankfully, we have Drs. Mark Wolraich and Joe Hagan here to talk about those standards. Mark L. Wolraich, MD, is the Sean Walters Professor Emeritus of Pediatrics and the Edith Kinney Gaylord Presidential Professor at the University of Oklahoma's Health Sciences Center. He has been active nationally in the American Academy of Pediatrics, particularly relating to ADHD. Dr. Hagan is clinical professor in pediatrics at the University of Vermont College of Medicine and UVM Children's Hospital. He is co-editor of the Bright Futures Guidelines, 3rd and 4th editions, the standard of preventive care for American infants, children, adolescents, and young adults. You can ask questions of Dr. Wolraich and Dr. Hagan during their presentation, and we'll try to get to as many of them as we can after they finish. If you want to download the slides of the webinar, click the drop-down menu labeled Event Resources on the bottom left of your screen. If you do not see the Event Resources tab, you need to refresh the page. That all being said, let's finally get to the webinar. Thank you, Mark and Joe, for being here today to help us make sense of things.
Thank you. I wanted to first give a little background in terms of where the guidelines are coming from. Pediatricians, to a great extent, have been involved with ADHD going back to before it was called that and was called miscalled function, and it wasn't until around 2001 that the Academy really was helpful in getting things much more clarified. Prior to that, the criteria for making the diagnosis was somewhat nebulous, and it wasn't clarified about treatment. So in 2001 and 2002, the Academy came out with guidelines both for diagnosis and treatment of ADHD. And then they were revised in 2011. And then most recently, what we're going to be talking about in 2019. And they really have made a difference in the quality of what pediatricians have in terms of making the diagnosis and treatment of ADHD. Were criteria that were set in terms of what were required to make the diagnosis and specific recommendations for treatment. And we know from surveys that have been done and studies that pediatricians have improved greatly in their evaluation and treatment. If I could have the next slide. The initial guidelines had a separate guideline for diagnosis and a separate guideline for treatment. The second one, and based on that, there were a number of continuing education projects that were initiated to help train pediatricians around the country. In 2011, we had two guidelines. The diagnosis and treatment were put together as one guideline, and then we came out with what's called a process of care algorithm that helped pediatricians specifically as to what they should be able to do in terms of both making the diagnosis and in treatment. And then for this recent guideline, 2019, we added an additional paper to the guidelines and the algorithm because we got a good deal of feedback from pediatricians about the challenges they and their families face in being able to implement the guidelines. So what we're going to talk about are the three papers. Can you have the next slide, please? First of all, back from when we started in 2001, we really decided we need to have uniform diagnostic criteria that was what could be communicated to our colleagues in psychology and in psychiatry. And so we really adapted the DSM system, as you can see, Diagnostic and Statistical Manuals of Mental Disorders, which then became DSM-4 and most recently DSM-5. The changes from DSM-4 to DSM-5 have been fairly minimal. The only things added is that if children are 17 years or older, they didn't need as many of the behaviors inappropriately present in order to make the diagnosis, and that whereas prior to DSM-5 and DSM-3 and 4, anyone who had to have presented with symptoms, at least by history, before the age of 7. We realized that from the research that had then taken place that particularly the inattentive type of ADHD really may not present because some children are able to compensate in the early years of school, and so it was changed to 12 years of age. Could you have the next slide, please? What we recommend in terms of evaluation is identifying those core symptoms so that they need to have sufficient, which is 6 or more of the out of 9 inattentive behaviors occurring inappropriately often, and 6 of 9 of a combination of hyperactive and impulsive behaviors. Most important is not just that they have the behaviors, but there has to be evidence that those behaviors are causing impairment, and that they're not due to some other cause as an alternative cause, such as learning disability, or what certainly is challenging for all of us clinicians and families is that a number of the other causes may actually be co-occurring conditions. So that we also recommend that it really entails reviewing the co-occurring co-occurring or what psychiatry calls other conditions. Next slide, please. And one of the additional criteria was that those behaviors, and particularly challenging in terms of performance, need to be present in more than one setting, so that rating scales have became an important part of it. Not that the rating scale in and of itself makes a diagnosis, but it helps the clinician to be able to actually go through all of the 18 behaviors and also some of the behaviors of co-occurring conditions, defiant behavior, and also anxiety and depression as part of it. One of the scales that is one that I had developed that is being used quite extensively, the Vanderbilt scales, and it was important to identify the more than one setting with having both parents and teachers fill out the scale. The demands on kids may well be very different within the home setting versus within the school setting. We did not intend the rating scales to be used alone, and and we keep reminding physicians that the rating scales alone are not diagnostic, that interviews are also a very important part of the observations. Parents and teachers are much more accurate reporters of the ADHD behaviors than children are. On the other hand, some of their co-occurring conditions like anxiety and depression are very important for getting children, because in that case, they're frequently the more accurate observers. And it's also observations of how the parents are dealing with the children is certainly another area. Next slide, please. In the initial guidelines, the strong evidence to be able to make a recommendation was from age 6 to 11 years of age. And so that was the initial criteria. In 2011, there was sufficient evidence to indicate that you could use the same criteria down to 4 years of age. And it also became clear that it goes on into adolescents and actually adults, so that the same criteria could be used for children down to 4 years of age. The challenge gets more difficult in making the diagnosis, and particularly if whether or not the child is in a school setting as part of it, in terms of trying to get a second observation on the child. That as to why actually preschool and behavioral program preschool children is an important component to be utilized in helping to make the diagnosis. Next slide, please. One of the important things that we emphasized strongly back from 2001 and continue to educate is that ADHD is a chronic condition. A number of the individuals, children identified with ADHD, are going to go on to have continual challenges even into adulthood. There are some effective symptomatic treatments for it, but they're not curative, so that it is important to look at it as a chronic illness, much as you would look at asthma or diabetes. And part of the elements of that are to educate parents and patients so they become experts themselves in the condition, develop a strong partnership so they're comfortable with their clinician, develop a plan with specific target goals. And I think that's very important. It has to be what you all as parents see as important issues that need to be addressed. And the team really should include the teachers since school is so importantly involved. And it's a process that requires continued ongoing monitoring, and you can anticipate that changes are going to occur as the child matures. Next slide, please. Communicate, and a big part of that is the communication between the families and their clinician. Not just in office visits, but through phone calls or portals or sending information on an ongoing basis. It's also important that the school personnel, particularly teachers, are a part of the team as well, since many of the challenges for the kids are occurring within the school setting. And in the kids who need additional care or are getting psychological care in terms of psychology, that there's good communication between the mental health clinicians and the primary care clinicians, between them and with the parents. Next slide, please. For elementary school age children, those 6 to 11s, we continued pretty much with the same recommendations that either FDA-approved medications, which are primarily the stimulant medications, and is the recommended treatment, but also that evidence-based parent and teacher-administered behavior therapies are also can be a recommended treatment, and it's preferable when possible for both of those to be employed with the children. Next slide. And it's important, particularly with the medications, to have to titrate, meaning that you start on a low dose and increase it to get a maximum effect with as few possible side effects as possible. And so it may take anywhere from a few weeks to a few months to really come down up with what they're doing. And we'll talk a little more when I talk about the medications. Next slide, please. So stimulant medications, which have been around since the 1960s, remain the first line of treatment. They are have the strongest effect. They don't work on all children, and sometimes you need to try one in the group of medications that have methylphenidate, and if that doesn't work, try amphetamine as both of the first-line treatments. And then there are two other newer medications that also have been shown to be effective, although not as strong an effect as the stimulant medications, namely atomoxetine, which goes by Strattera, and alpha-2 agonist guanfacine, which goes by Intuniv, and clonidine, which goes by Capfe. Next slide. It's important to use behavioral therapy in terms of what's being done. It, first of all, can be used in children who don't respond to medication. It can be used if parents refuse or are hesitant to have the treatment. It requires a good effort on both the parents and teachers to be able to do it, but it certainly is effective treatment. And frequently with behavioral treatment, if you need medication, can have lower doses of the medication as part of it. Next slide. Behavioral interventions are basically a reward system, as you can see, of the different interactions that are that go on during with that. And they can also be ensure structural and predictable routines in the classroom, and a structured situation and the same type of behavioral techniques that can be used by parents are ones that work well with the teachers. With both of them, there again are symptomatic treatments, much as you treat asthma with medications, but don't necessarily cure it. Same with diabetes. The same with both medication and behavioral interventions. They don't necessarily result in a cure for the condition. Now, there are going to be children that, as they mature, really develop skills that are able to compensate well for their condition, and particularly as their environmental demands may change, may no longer need specific treatment. But there are also a number of patients, in fact, the majority with ADHD, that do continue to benefit from treatment even as they go into adulthood. And in fact, for the preschool children, those 4 to 6, behavioral interventions are the first recommendation for treatment, because the evidence is stronger in terms of the behavioral treatment rather than the treatment, rather than the medication, although medication also is a benefit, but not as strong an evidence. And when we say behavioral management, we're really talking parent training behavioral management. So it's programs where the parents learn how to be effective reinforcers of appropriate behavior in the children, and what things they can do to reduce the inappropriate behavioral treatments. That continues to be a challenge for parents and primary care clinicians to find, because they're not always available in the community. A number of the behavioral interventions for the young children are play therapy, and that really has not shown evidence to be efficacious for children with ADHD. And then there have been a number of additional treatments that have been recommended, but we did not recommend them in the guidelines, because in reviewing the evidence of studies to meet rigorous scientific evidence, none of them had at this point reached the same level that you see with the evidence from medication and behavioral management. So in summary, ADHD is real, and the amount of research in this area is voluminous and goes back from the 1960s through till today. In fact, one of the challenges in revising the guidelines is how many studies have to be reviewed for the case. From the epidemiologic studies, despite the perception that too many kids are being diagnosed, there's still evidence that there are a large number of children who meet the criteria for the diagnosis but have not been diagnosed and have not received treatment. And so with that, I'll turn the rest of the talk over to Dr. Hagan to speak specifically on the focus of what the primary care what you can expect from primary care doctors.
So thank you, Mark. Thank you, Dr. Wolraich. I'm happy to take over and talk about the ongoing care As you might guess, Dr. Wolraich and I have been friends and colleagues for a very long time and have worked on this topic and others. Mark is a specialist in developmental and behavioral pediatrics, and I am a generalist. I am a primary care pediatrician. That's what I do for most of my life in Burlington, Vermont. So I'm going to talk to you about working with your child's primary care clinician, be that a pediatrician, family medicine physician, nurse practitioner, physician assistant, any of the clinicians who might assist you in the diagnosis and the care of your child when ADHD is a consideration. We hope that you'll be dealing with folks who are experienced in diagnosing and managing ADHD and other behavioral health concerns in children and adolescents. And we're going to talk about how their practices might be organized to provide this care effectively. May I have the next slide, please? So, as Dr. Wolraich noted, ADHD is a chronic condition. And it is, I think, one of the first goals of the treating clinician, pediatrician or others, to educate parents and patients about ADHD. This is something that will be best served in partnership between the medical home and the family and the child. One wishes to develop a management plan with specific targeted goals. Some of those goals are mine. Some of those goals come from teachers. But, parents are the ones who know what their child needs the most. Parents know. So very much what parents view as the goals are key to successful case management and ongoing monitoring that anticipates the fact that as children grow up, the needs will change. Next slide, please. Practice resources nowadays can be organized to support families and children where there are special health care needs. And from that comes the concept of a family-centered or child-centered medical home, where parents and children are seen as partners with the clinicians, where care coordination occurs. We work together, where, when necessary, care conferences bring together clinicians and families and sometimes older children with teachers and special educators and behavioral health clinicians who are involved as well. This is the primary care practice medical home for which there is certification, and you can probably find if your own practice is certified as a medical home simply by looking at their website. Next slide, please. So, as I suggested, every child needs an ADHD team. That's you and your child. That's the primary care doctor or other clinician. That perhaps is a practice care coordinator. That could be a nurse in our office. That's a master's in social work. Teachers, special educators, school administrators, behavioral health practitioners, and medical consultants. Those will make up those are the people we typically would see in ADHD team focus. Next slides, please. Because we know that excellent care employs communication between families and clinicians other than just in office visits. There's also communication between clinicians and school personnel and communication between primary care clinicians and mental health clinicians. Next slide. Because the teacher is very much part of the team. She is essential for your child's diagnosis. He provides really invaluable feedback to parents and clinicians about the treatment's success or failure, and they teach. Your child may have a Section 504 plan as an important component of ADHD care, which guides the teacher for classroom-based settings and notifies the teacher that in their classroom is a child, your child with ADHD, who learns differently than the majority. A few children, some children will need an individualized education program to address their special needs in special education, which would be given outside of the classroom. Next slide, please. But there are barriers to care, and Dr. Wolraich mentioned that at the beginning of this talk. But here are the things that tend to trouble people like me when we're working with people like you. There's limited access to care because there's inadequate developmental, behavioral, and mental health training during residencies and other clinical training, and shortages of consultant specialists and referral sources. pediatricians during their residency need to learn a lot of things, and a lot of what you do in practice is trained during your hospital residency. But there's a lot of things you learn when you're out in the world and in the clinical world of your practice. The behavioral and mental health training is increasing during residencies, but it's very hard to introduce enough of that training to allow people to feel competent as soon as they come out. We always like to know who are our friends that we can call when we have questions. What friend can we phone? And if there are adequate numbers of consultant specialists in behavioral pediatrics or mental health, that can be very supportive to us, and then we can support you. Second, the payment for the services and payer coverage limitations for medications are a chronic and relapsing problem. One interesting thing to come out of the current COVID-19 pandemic is that we finally now are able to use telemedicine and telephone care in a more appropriate way. And there is finally some payment for that. Previously, there was little or none. One of the things that's greatly frustrating to me and other pediatricians is that insurance payment for the ADHD medications that we might choose is, it's capricious sometimes and often feels arbitrary. We may have a child happily taking one medicine, and their insurance changes, and we must change to another medicine. And I think that's a real problem in our system. There are challenges in how practices are organized and staffed to be able to meet your needs in terms of telephone connections and care coordination. And there can be fragmentation of care and resulting communication problems because of barriers to the communication of the people who are involved. So let's drill down more deeply on this. Next slide, please. Limited access comes from limited time to train in residencies, as I suggested before. Limited affordable continuing medical education activities are available in this area. They tend to be out of town. They tend to be expensive if they're excellent. There are financial disincentives to pediatricians and family docs going into specialty training, the additional training of behavioral health specialists in medicine and psychiatry. The additional years spent in training often do not reflect changes in income and often make less than you would make in primary care. And not all practices embrace the medical home concept of service. So there are we need to do a better job within medicine making this system work for you. Next slide, please. Secondly, payment. Well, if you don't get paid for the services you provide, it sort of speaks for itself that those services might not be available. So much of this care, as I said a minute ago, is not face-to-face. Now, new accountable care organizations, or ACO models, they really have to account for care coordination, and the ones that show promise do take that into account as they're thinking about their payment mechanisms. Insurance limitations on ADHD medications I spoke about before is a chronic problem that we could fix if we chose to. Next slide, please. There are challenges in practice organization. I always say when I'm teaching residents and medical students, these are not the usual sick call visits. The worst way to try to diagnose ADHD is when you've finished diagnosing a sinus infection or a bellyache, and while you're leaving the room, the parents say, oh, by the way, can we talk about this ADHD problem? Well, yes, we can, but we can't probably talk about it at the same time that we're taking care of the sinusitis or the bellyache. There is a diagnostic process of accumulating both home and school information, which Dr. Wolraich discussed at length. This is not often supported by health insurance, and it's difficult to work that into a practice in a way that's going to be efficient. And ongoing communication with family, school, and mental health currently provides little or no financial payment for time spent by any of those people. Next slide, please. Fragmentation of care can result in communication barriers. We must work together. Yet there are limitations on what we can share. Doctors talk about HIPAA in terms of patient privacy. Educators talk about FAAP in terms of privacy for students. And both systems allow for workarounds. Both systems allow for communication sharing, but we must work to establish these communications. There's hope that we could do this in the context of an electronic health record. Some are within a practice's electronic health record, but then they are difficult for people on the outside to access. Some online communications are outside the electronic health record, but then they can be difficult for me to access. So there are barriers to the work we do, but we've made tremendous steps forward in the past 10, 15 years with the medical home movement and care coordination, and we can feel optimistic that this type of service is going to provide better care for all kids with ADHD. Next slide. So in summary, effective treatment considers ADHD as a chronic illness that requires ongoing treatment, appropriate medication management with titration, meaning change of medication as needed, ongoing monitoring, and most importantly, collaborative care that is family-centered and family-based. Thank you.
Thanks so much. That was excellent. Lots of questions, so I'll get right to them. And you guys can decide who wants to answer what. How often should pediatricians be communicating with patients when they're starting a medication?
I can answer that. If you're starting with the stimulant medications, one of the things about it is they show effects pretty much immediately within the day you take it. But getting to what's the right dose takes a while. So we usually recommend that there be some weekly communication until you figure out the right dose without the side effects. Now, the challenges of that is it's not compensated easily. But on the other hand, the child and the parents don't necessarily have to come in for a visit for that. That could be done over the phone, or if there's a portal with having the rating scale sent in through the portal, or have the rating scales faxed in. And so changes can be made weekly to get to the dose, at least with the stimulant medications. And the expression we use is start low, since there are some big kids who may respond to a low dose and small kids who need a large dose, but go fast, as opposed to most other medications for behavioral problems that are start slow and go slow.
In our office, we like to see children and families back in the office in about a month, but we very much depend upon phone contact, either with our phone nurses or via our electronic patient portal. We like to hear weekly because, as Dr. Wolraich has suggested, with the stimulants, we're usually able to make a dosage change on a weekly basis if need be. I tell most parents that what I'm most interested in at first is a simple question. Are you seeing an effect? I'll then follow it up with what sort of effect, but we just want to know, are you seeing any effect? Because when these medicines are properly prescribed based on a good diagnosis, you can usually see an effect when you get to the right dose pretty clearly.
And we've talked about a target goal, which is important for families. It's what you see as is the big problem that you want to try to see improved. And so apart from just getting better scores on the rating scales, is it really making an impact on the thing that you see is really a problem for your child?
Good point. What is the main reason for starting a child on medication under the age of 6? A lot of parents are reluctant about that, and they want to know the reasoning behind it.
It's the second line treatment, because we strongly recommend that behavioral interventions be tried first. But there are going to be children, there were about a third of the children in the studies that were done that improved clearly with behavioral interventions. There are going to be children that will need treatment of medication in addition to that. And there is pretty strong evidence that the medications work in the same way they do with older children. There isn't as many studies as in older children, but there are good enough studies that it is an effect. So if you try the behavioral intervention and it's not working, or if you're at a place that you can't find any of appropriate behavioral interventions, then medication, stimulant medication does work and is relatively safe.
I think it's a bigger decision for parents. It's a bigger decision for every pediatrician I know to use it on a younger child. We want to do this carefully. I personally feel that the diagnosis is a little trickier in younger kids because you have to decide what's normal behavior versus what's abnormal behavior. Yet I think that, like Dr. Wolraich, I would say that we don't wish to use meds if we don't need to, but you would. It can be dramatically effective in kids who are tremendously impaired and held down by these behaviors that they cannot control. And I have come to the point where in my career where I do not believe that we need to hold off treating these kids just to meet some magical age.
Mm-hmm. Yes, I understand. We haven't discussed comorbid conditions, the diagnosis of such with ADHD or alongside ADHD. How much more, one parent wants to know how much more, and also a special education teacher, how much more complicated and involved is that, let's say with anxiety or depression?
Well, it's complicated both in the diagnostic stage and in the treatment stage. It's complicated diagnostically because some of the symptoms of anxiety are inattentiveness, and inattentiveness can lead to impulsivity in kids. It's also complex from the other side because many kids who have tried and failed and just not connected in the classroom or in the social setting because of their ADHD, guess what? They get anxious. So they can mimic one another, but they also are frequently seen together. And that's why I think that seeing this as an ongoing relationship, recognizing that every month or every in the early stages and on a regular basis afterwards, you need to touch base. We need to be in contact so that we can make sure that things are going well and help you address concerns as they arise.
Yeah, and the majority of the children with ADHD will have at least one co-occurring condition. Many will have some learning challenges that need to be dealt with, and some of the other co-occurring conditions, such as, for instance, anxiety or depression, may not show up till the child is older, 10, 11, or as an adolescent.
Mm-hmm. Do the physicians provide the rating scales? This parent asks, I've been told to ask the school to do the rating scale assessment, and the school says the pediatrician should do it. So can we clarify that?
You should be able to expect that your pediatrician will give you the rating scales. There are pediatricians who work closely with the school system, so the school has the rating scales too. The rating scales I referred to that I had worked on, the Vanderbilt scales, are out in the public domain, so there's no cost other than for copying them. And it'd be appropriate for parents, if their physician is not using any rating scales, to ask about that, because they can get it. They can get it through the academy. There's also a website where they can download it at no charge as well.
I couldn't agree more. I think that few people nowadays are not using rating scales to assist in the diagnosis and to document what their findings are. They're very useful in assessing treatment success or failure. The Vanderbilt forms are, easily downloadable. Just Google Vanderbilt ADHD; it'll pop right up. And there are other tests that can be school administered or physician ordered that can also be used for this. It could be used to screen for co-occurring conditions. These will usually be something that you and your pediatric clinician decide to use together.
Mm-hmm. What's the best way, parent is asking, what is the best way to locate an appropriate behavioral therapist in one's area besides doing a Google search?
I personally wouldn't do a Google search because few Google searches are going to give you that type of depth. I think that if they are available in your community, your pediatrician or other primary care clinician will probably know who they are and have specific referral sources. If they aren't, it's okay to, when you call a therapist, they're going to ask you what the problem is and who your health insurance is. You can ask them, what's your experience with ADHD? Do you use parent training in behavior management? And if they say, no, I use play therapy, well, that's kind of a dated approach that's been shown to be less effective. Mark?
Yeah, and you can get some sense in terms of the therapy they're offering is to work directly with the child most of the time. That's not the parent training and behavioral management, because it really requires parents to essentially become effective at being able to manage their children's behavior for it to have a lasting effect.
And while we're on behavioral therapy, is behavioral therapy covered under most insurances with a diagnosis code of ADHD?
It's very variable. It all depends on what the insurance coverage is and what type of insurance they have. Unfortunately, it is not covered by all, and we've certainly gotten feedback from pediatricians that the only thing that they do cover is play therapy as part of it. So you need to have it. Now, there is a more intense form where the therapist is working one-on-one with the parent and child. There are others that are a little bit less expensive, where it's the therapist may have a group of 5 or 6 parents who practice the behaviors on each other and then go home and try it on the child and then come back. And those are both effective. Obviously, one-on-one stronger effect. Both of those types of therapy work.
Dr. Wolraich, are you still there with us?
Yes, I'm still here. Was that clear what I said, or do I need to repeat it?
I think we got everything but the last sentence.
I was just saying, my last sentence was that the way to figure out if the therapy is effective or not is it helping you as parents, and are they spending the time? And there are some of the forms of parent training and behavior management where there may be a group of parents working with the therapist, doing some role play and practicing on each other, taking it back to their children, and then coming back the week after. And that is also effective as treatment.
Okay. This one is a more general cultural question. How do we as practitioners help parents of children who are ethnic minority, who break the stigma, they're not seeking behavioral mental health, and not interested in having their child take medication? Have you run into any situations with ethnic minorities who might have some built-in, reluctance to do that? How do you handle it?
I think it has a lot to do with, building a relationship. I mean, I and certainly when I've taken care of refugee resettlement families here in Vermont, which are pretty common, there's a learning curve in what is the expectation of educational experience, learning curve, and what's the expectation of behavior. I have no doubt that ADHD as a problem is found in all human beings, but how it's perceived as a problem, varies, I'm sure, from culture to culture. Then there's going to be a decision that has to be made along with that family about what is a problem and what is not. Some of that involves the education of the family of how our system works and how to get the best out of a child's education in our system. But so I think there's a lot of cross education that is required between the cultures to adequately serve these kids. And I will say that every time I've been involved in one of these cases, I have learned as much as I have taught.
And I think both Dr. Hagan and I, the reason we've emphasized how important the relationship between the clinician and the parents are and the children is so important, because you want to be there to help them, and if you develop a relationship with them, you're more likely to be able to be of help, even if there are limitations to what they're willing to want to utilize in the care of their child.
Mm-hmm. Here's one that comes up quite a bit. Is neuropsychological testing needed when making a diagnosis of ADHD?
It is not specifically needed in making a diagnosis. And when we reviewed the literature again, there wasn't evidence that it was any more accurate than the process that we talked about. It is used more in adolescents and young adults who don't have a prior history of having ADHD, because of the concern of medication, specifically stimulant medication, being used as a performance-enhancing drug. So neuropsychological testing is frequently required if it's an adolescent or an adult without a prehistory of ADHD, and that's only because it's much better at picking up individuals who are faking the symptoms to be able to get medication.
The other time I think it's called for is when there's a lot of complexity with other co-occurring conditions, educationally, yes, behaviorally. Or in my own case, I've certainly been interested in it when I have been surprised by a treatment failure, or found that the usual modalities of treatment were not working. Sometimes symptoms that look very much like ADHD can be symptoms of something else, such as fetal alcohol effect or lead poisoning. These can all, give you features of attention difficulties, which are not ADHD, and then sometimes neuropsych testing can help us drill down as to what that problem is to try to address that.
Mm-hmm. I guess this comes from a school, social worker or school psychologist. What documentation can a school district expect from physicians when we are considering / discussing accommodations for a student based on a medical diagnosis of ADHD? Often we just get a medication script without any other data or insight into the process of diagnosis.
So I think that you will find that few primary care clinicians know the answer to that question. So my answer to that school therapist or special educator is, tell us what you need. Now, I frequently write letters certifying the diagnosis, which families then use with their educators to craft a Section 504 plan, or in the less common case, the IEP. But I think it's okay, with the family's permission, to be in touch with us directly and saying, this is what we need to provide the services that we believe this child needs. I would be hard-pressed to expect that a primary care clinician wouldn't welcome that kind of a call, because it shows that we're in this together, and that gives us a chance to build a team.
And I think that's one of the reasons why we also emphasize the importance of educating parents and patients about the condition, because the parent is the one who's going to be more effective at getting the needed school interventions for their child than the physician will. The schools tend to not like to be directed by clinicians that they don't perceive as knowing the education, but there clearly are rights that children have that parents can push for. And so one of the things we encourage primary care clinicians is to know about the things, as Dr. Hagan referred to, the 504 plan or the IEP, and what their child should be able to get within the school area. Another important area is on the issue of bullying, which can present with symptoms, and is important for it to be addressed in the school.
Mm-hmm. Okay. And I guess lastly, I hope this you can provide, I don't know, an effective but reasonably brief answer, and that's one about what can you do if you feel that your doctor, the parent feels that the doctor has misdiagnosed the child? I mean, get another opinion, talk with the doctor in depth about the evaluation. What are your thoughts about this? It's sort of a patient empowerment type of question.
Well, as the primary care doc on the line, I would say, if you think I'm wrong, please tell me and tell me why. Because either I am or I haven't explained it properly. And I think both of those are poor outcomes. They're not what I want for your family and your child. And sometimes a gentle nudge that it might be good for me to think about a second opinion or a consultant. Boy, I would welcome that and be happy to talk about that.
Yeah, I would agree. I think that most of the primary care physicians are not hesitant to wanting to get a consultation. The bigger challenge is finding who they can send their child to, because the number of, for instance, child psychiatrists are pretty limited and usually have long waiting periods. And that's part of the reason why we also are trying to boost up the abilities of what primary care doctors can do. But it can be very frustrating both for the families and the primary care physicians in terms of getting help.
Right. Well, I think the hour is up. Thank you, doctors, for being here and sharing your expertise. It's very enlightening to me. So thank you again.
It was a pleasure. Thank you for having me.
Thank you. Yes.
And thank you, Dr. Wolraich. Yes, it was great having you. And thanks to all the attendees for listening in. Just want to point out that Play Attention was the sponsor for today's webinar once again. And please join us next Tuesday on May 26th when Rick Green will talk about the ADHD Guide to Fighting Stigma. Thanks, everybody, for being here, and have a great day.
For more Attitude podcasts and information on living well with attention deficit, visit attitudemag.com. That's ADDITUDEMAG.com. That's ADDITUDEMAG.com. That's ADDITUDEMAG.com.